In this section, we're going to cover headaches. And we're going to look at the different types of headaches. We'll look at migraine, tension, cluster headaches. Then we'll look at headaches that we might call non-benign. So non-benign would be more ominous, like brain tumors, things like that. We already examined the tumors in a previous lecture. We'll look at CNS infections because they often manifest like meningitis, encephalitis as headaches. And then we'll look at all the headache red flags. So headaches are extremely common in the clinic. So we have many patients with headaches. And it's important to know a little bit about when do we have to be concerned about the headache. Is this something benign, something that'll just go away with some rest and some basic treatment, or is this indicating something more ominous? One way to look at headaches is to really differentiate them into acute, subacute, and then chronic. And the chronic could be episodic, meaning they come and they go, but over many weeks, months, years. Acute onset would be seconds to minutes. Subacute would be hours to days, and then chronic would be longer than that. So let's look just quickly at some of the causes of acute headaches. So the primary would be like a new migraine or cluster headache, just you never had a migraine, but it's your first time and you had one. But it could be, and often more commonly, it could be vascular. So it could be an aneurysm causing the subarachnoid hemorrhage. There could be cerebral venous thrombosis. There could be what's called cavernous sinus thrombosis. We'll talk about that one later. Cavernous sinus is the area around really around the pituitary gland, where a bunch of cranial nerves pass through, and there's a bunch of blood vessels as well, and that can become, you can actually develop a blood clot there, and that can cause edema, swelling, and so forth. Cranial cervical dissection, that's where a ruptured vertebral artery occurs. Acute severe hypertension, a stroke, cerebral vascular accident, and then a pituitary stroke. Pituitary apoplexy, remember we talked about that in the pituitary section, is when the blood flow is compromised to the pituitary. So we have a collapse of pituitary function in its activities. Increased intracranial pressure from obstructive hydrocephalus, for example, and then acute ocular disease like angle closure glaucoma. That can also cause an acute headache. So acute, we're going to be a little bit more alert at looking at, all right, is this just the first time you've had a migraine, or do we have something more serious going on here? So we want to look at all the signs and symptoms I'll talk about here. For example, of increased intracranial pressure, like the nausea, vomiting, the papilledema, if we look with the ophthalmoscope, sudden double vision, that sort of thing would be more concerning. Subacute, again, could be a new onset migraine or tension type headache. Could be from infections, so we'll talk about meningitis and encephalitis. It can be vascular ischemic again, so all the CVA things we've talked about. Subacutely increased ICP could happen in large tumors or even altitude sickness. Pseudotumor cerebri, I'm not going to talk much about that, but I have seen several patients with this. They have all the signs and symptoms of a brain tumor and increased intracranial pressure, but their imaging is completely normal. There's no tumors present, but they don't have anything obviously blocking their cerebrospinal fluid, and so we call that pseudotumor cerebri. And then subacute ocular disease, anything with the eye, so iritis, keratitis, scleritis, orbital infection. Again, we'll talk about those in an ophthalmology section separately. And then chronic headaches, our primary ones would be migraine, cluster tension, so we're going to discuss those in depth. Infectious headaches like chronic sinusitis, and then medication overuse, caffeine and NSAIDs, trigeminal neuralgia, for example, TMJ, and then cervical arthritis. All these can cause chronic headaches. All right, so when we take a history on headache, it's important to get a lot of detail. So we should really do a full evaluation with chronicity, the intensity, the location, duration, the variation during the day, the triggers, provocative factors, palliative factors, and then patient risk factors. So if they're high risk, with age, if they're immunocompromised, pre-existing malignancy, etc. If we see things like fever or rash, then we're going to think here meningitis, like meningococcus and other infections. If we see jaw claudication, that might indicate temporal arteritis. That's where the temporal artery in the temple becomes inflamed, some autoimmune condition. And then constitutional symptoms like weight loss, night sweats, all of this, these would all be red flags for tumor in general. So we always ask those general symptoms. If you notice any significant weight loss in this last several months that you haven't been trying to achieve, are you having night sweats, those are 2 potential red flags for cancers. And then photophobia, nausea, vomiting are going to be more typical of migraine. But again, subarachnoid hemorrhage or meningitis might present with more stiff neck. Remember, subarachnoid hemorrhage is thunderclap headache, severe, sudden onset headache. And then neurological sequelae like diplopia, mental status changes, or papilledema, that's going to be telling of more serious conditions going on. When in doubt with a headache, refer. So if you're not sure what's causing this patient's new onset headache and they're having some of these neurological changes, it's probably time to refer to the emergency department to have them worked up. They might need a CT scan or a lumbar puncture to get further information on that. So that would all be part of the history and workup for headache. I didn't talk about physical exam, but obviously doing as adjunctive providers, you're not doing full PEs. But if you know some of the components of the neuro exam, it could be helpful to get more information that way. But again, when in doubt, just refer. So probably by far the most common headaches are tension headaches, and they are bilateral typically. So both sides of the head. They last between a half an hour to 6 hours or more. Usually constant pain, kind of a tight band-like pain across the forehead. There's usually no sensory phobias. In other words, light and sound don't particularly aggravate. No nausea, vomiting, or visual auras where you see spots in the visual field or dark things or things like that. Brought on usually by fatigue or stress. Very tight upper back muscles is a very common reason. And there might be nonspecific symptoms of anxiety and poor concentration, insomnia, and usually occurs later in the day. So usually the mornings are fine, and then it's usually midday and late in the day people get tension headaches. This is typically a diagnosis by exclusion. So you usually rule out all the other more serious things. So for example, giant cell arteritis in patients, the temporal arteritis. Usually here we're going to have older patients with very severe headache on a temple. Feels kind of burning and severe. And that needs to be evaluated pretty quickly because that can lead to permanent visual changes due to problems of the temporal artery. So we need to get what's called an ESR, erythrocyte sedimentation rates, a blood test. If that's elevated, that might be a marker for the temporal arteritis. But typically tension headaches, we usually address therapeutic order levels 1 through 3. So relaxation, massage, hot baths, avoid triggers, maybe some NSAIDs, acetaminophen. Triptans are drugs used for migraines, but they do have a role in tension headache. But usually our herbal therapies, acupuncture, that sort of thing would be maybe what we'd start with. Migraine headaches, again, very common, very difficult to treat long term. But these are typically unilateral and they're repetitive. Usually they last up to from 4 to 72 hours. Affects females more than males, maybe familial, and usually the onset is in the early 20s, but it starts much earlier. Sometimes it starts right at puberty. Pathophysiology, there's what's called vascular hypothesis, and that is that we get vasodilation of the blood vessels around, under the scalp, around the trigeminal nerve and in different parts of the brain, and they leak out all sorts of pro-inflammatory mediators and so forth. Calcitonin gene-related peptide, CGRP, is a big one that's being investigated now, and so that triggers a lot of the sensory nerves, like the trigeminal nerve, to fire, and so we feel pain. The neural hypothesis, which is more predominant now, is that there's actually a wave of neural depression spreading throughout the cortex of the brain. So sometimes it starts back at the occipital cortex, and so people will start to see visual auras and changes. And so then it spreads forward into the temporal or maybe parietal lobes, and it shuts down all those areas, and we start to see loss of different functions. So that's called the neural hypothesis. Usually they go together. So where the blood vessels dilate, they release their inflammatory mediators, then the nerves stop firing as they should. And then again, the pain from migraine is usually linked to the trigeminal nucleus activation in the brainstem. So where the trigeminal nerve cell bodies reside, they get activated, and that triggers pain. Usually the history shows a throbbing headache, usually more than 2 hours, but typically less than a day. almost always less than 72 hours, with nausea, vomiting, photophobia, sensitivity to light, and then noise sensitivity. Headache is usually relieved by sleep and stress. And then classic migraines are usually unilateral, and they're preceded by what's called the visual aura. And that would be bright or flashing lights in the visual field. Those are called scintillating scotomas, or visual field cuts, where you actually lose part of the visual field. And then common migraines may be bilateral or periorbital without the auras. So you don't have to have an aura to have a migraine. So classic versus common migraines are a little bit different. Typically here, again, addressing therapeutic order levels 1 through 3 can be helpful. So on level 3, I mentioned that, for example, riboflavin B2 has been found to be helpful together with magnesium. Removing potential dietary triggers would all be helpful. We do know there's tends to be a hormonal fluctuation with these, and so addressing liver function, all that with herbal therapies is all part of level 2 therapy would be important. The level 4 approaches typically would be either abortive therapy with NSAIDs or a drug class called triptans. The triptans are vasoconstrictors, so they constrict the arterioles to prevent them from dilating and leaking out all of their stuff. And then there are anti-nausea medications, adenosatran or Zofran, metoclopramide, Reglan, promethazine, Phenergan, and so forth might be used. I think the Zofran is probably most prescribed. It actually comes in dissolvable tablets under the tongue, so you just dissolve it in your mouth, and can be very helpful for the nausea of migraine. And then for prophylaxis, sometimes anticonvulsants are given, like gabapentin and Topamax, topiramate. These have a lot of other adverse effects, especially the Topamax, so really knocks people out, and so not really great for long-term necessarily, but for patients with very severe migraines, sometimes they would rather do that than suffer the migraine. And then tricyclic antidepressants, amitriptyline is one. We're also seeing the SNRIs. We'll talk about this drug class later. Selective norepinephrine reuptake inhibitors like Cymbalta are being increasingly used as well, and especially if a patient has either anxiety or depression with the migraines, that might be a drug class that's used. Sometimes beta blockers like propranolol are used. They just block your sympathetic nervous system. Again, we'll talk about those later. And then calcium channel blockers. These are less common, but I put them on the list just to make it complete. Typically, triptans and Zofran would be a common combination, maybe with an SNRI, etc. Okay, so that's migraine headache. I'm not going to discuss the organ patterns with migraine. That's usually discussed in your herbal classes and acupuncture classes. Cluster headaches would be unilateral headaches. They're 15 minutes to 3 hours in duration. They're repetitive. Males, in this case, are more affected than females, and the average age of onset is around 25. They're brief, excruciating, unilateral. They're usually around the eyes. Again, lasts 30 minutes to 3 hours. And usually there's a lot of restlessness. So the patient feels like they move around just to get some relief. Attacks that tend to occur in clusters, affecting the same part of the head at the same time of day. And they can also happen during sleep. And they're aggravated during different seasons of the year. Usually there's tearing on that eye, so ipsilateral lacrimation. The conjunctiva look injected, so they'll have the redness in the conjunctiva, the white of the eye. Looks like little broken blood vessels in there. Horner's syndrome, where there's actually changes in the sweating and eyelid drooping on that side of the eye as well. And then nasal stuffiness. And this has to do with activation of the autonomic nerves that innervate these regions. So the classic presentation is a headache, history of repeated attacks over an extended period of time, and usually we don't need any further evaluation. But the first episodes do need workup to rule out other conditions like the cavernous sinus infection and so forth. So typically new onset cluster headaches need a more thorough workup. The acute therapy would be actually oxygen, ergotamine, so dihydroergotamine, it's an ergot alkaloid. It's a vasoconstrictor, and that seems to have benefit. And then octreotide, this is somatostatin analog, and then sumatriptan or zomatriptan. These are triptans, same that are used up there in migraine. And then prophylactic therapy would be things like prednisone and, again, an alkaloid ergotamine, and then calcium channel blockers, verapamil, and several others on the list here. So those would be kind of the biomedical approaches for cluster headaches. Not as common as the tension or the migraine, but we consider this to be a benign headache. It's not associated with other more severe neurological problems. Unless, again, first-time cluster headache, we should work up, should send a patient for a thorough workup to make sure there's not something else going on. Okay, so that's 3 what we consider to be benign headache types. So I mentioned briefly temporal arteritis. We also call this giant cell or cranial arteritis. This is an autoimmune inflammation of the blood vessels. That's called a vasculitis in the brain and the scalp. Usually almost always affects those over 50, more common in males than females. And patients might also have what's called polymyalgia rheumatica, which is an autoimmune condition, and that causes very severe muscle aching and pain throughout the body. These typically are severe one-sided headaches in the temple, and their tenderness. So if you just palpate the temple, it's very, very sore to the touch, and that pain radiates to the scalp. There's usually facial pain in the jaw and pain in the mouth with chewing. And this can be associated with inflammation of the retinal artery, and that actually can cause permanent blindness. So this is something that we don't consider to be a benign headache. It needs more aggressive treatment. Physical exam findings would include the symptoms I just talked about here and the signs, but then labs like the increased ESR, erythrocyte sedimentation rate. Erythrocytes are your red cells. When there's more inflammation in the body, they tend to stick together faster. So what you do is you just draw a patient's blood in a tube, and you see how quickly it takes for the red blood cells to all settle out on the bottom. The more inflammation in the body, the quicker they're going to settle out. And so that's going to tell us a bit about inflammation. And then CRP is another marker. That's a liver peptide, liver protein made in inflammatory states. Typically, to work this up, we need to do what's called the biopsy. We have to take a biopsy of the temporal artery. So that would be the definitive workup. This is a medical emergency. So if you suspect someone has temporal arteritis, refer to the ED right away. And they need high-dose corticosteroids. Again, if this is affecting the retinal artery, this can result in blindness. They might actually need low doses of steroids for years, and then they'll need to do a taper on the steroids. So we haven't talked about corticosteroid tapers, but this is one medication where if a patient is on a high-dose corticosteroid, like prednisone, let's say 60 milligrams of prednisone, for more than a few days, you cannot just stop that prednisone. If you do, they can go into an adrenal crisis, which can be fatal. So this is one drug class that needs to be tapered. So corticosteroids of any type that are used for more than a few days, especially at the higher dosages, have to be tapered. Okay, so that's temporal arteritis, non-benign kind of medical emergency. Cavernous venous sinus. So this is cavernous sinus, and I don't have a picture here, but you might want to go look up a picture of where the cavernous sinus is. It's basically, like I said, around the pituitary gland earlier, and this it's kind of in the central part of the face, and this can result in what's called septic thrombosis of the cavernous sinus. And it's usually you have a bacteria, Staph aureus, that infects, sometimes fungi, and this basically creates a facial headache. You can have orbital pain, edema, swelling, double vision, visual disturbances. There's often been a recent history of sinusitis or facial infection or tooth abscess in the upper jaw. Patients appear ill and usually have a fever. They have a red eye with maybe an eyelid drooping, that's ptosis, and then changes in their mental state, confusion, drowsiness, even coma. And that suggests the infection is spreading to the central nervous system or sepsis. So we look at our physical exam findings here. Labs would typically reveal an increased white cell count. Blood cultures would be drawn, and then cerebrospinal fluid might be examined with a lumbar puncture. Neuroimaging with MRI and contrast would be indicated, and then often a biopsy of the sinuses as well. Here too, medical emergency. So patients need IV antibiotics, usually for 3 to 4 weeks. and they need often a combination of several agents, maybe even antifungals. And then surgery to drain the region if the antibiotic response isn't adequate within a day. So that's cavernous sinus thrombosis. That's another type of non-benign headache. And then we've already talked about increased intracranial pressure. Whenever you suspect this again is a medical emergency. And that's usually going to be the classic symptoms of nausea, vomiting, double vision, severe headache, worse in the morning or worse with bending over, impaired loss of consciousness, double vision again, constricted pupils, irregular breathing. This can have many causes: infection, trauma, toxins, hydrocephalus. It can cause that herniation syndrome, where again portions of the brain are displaced through the foramen magnum or through the dural openings, like the uncal herniation. And then chronically, so that would be acute increase of intracranial pressure. Chronically, you get a gradual rise of intracranial pressure, and we get progressive headaches, nausea, blurred vision. Headaches are usually, again, worse in the morning, gradual change in consciousness, and then here typically we see tumors and hydrocephalus as the major causes. So we'd find our characteristic findings on history and exam, and our CT scan is usually what's done for the imaging. And the therapy usually is to get the intracranial pressure down with hyperosmotic solutions like hyperosmotic saline or mannitol, and dexamethasone steroid. And then maybe the peritoneal stent is placed, where we shunt the cerebrospinal fluid down into the peritoneum for drainage, and then removal of any tumors that might be blocking drainage of CSF. So that's another non-benign headache there. Say just a few words about the two most common brain infections, and that would be meningitis or encephalitis. So meningitis is inflammation of the meninges, and the classic symptoms of acute meningitis would be severe headache, stiff neck. They usually develop over several hours. Confusion, fever, nausea, vomiting are pretty common as well. Patient lies with their head arched backwards, and that takes less pressure off the meninges, and so they have their head arched backwards, and that relieves some of the pain. If they start getting confused with this, that's a really serious sign, and that's all of this is a medical emergency, but that's very serious. And usually meningitis can be caused by either bacteria or viruses. The most common bacteria would be Neisseria meningitidis, and that's also known as meningococcus, and that causes meningococcal meningitis. That's the one most people have heard about. This is a severe form, and it has actually a bruising rash. It has leg pains, cold hands and feet. So meningococcus, the rash on the body, looks like bruises on the lower legs, for example, is a pretty characteristic sign of meningococcal infection. There is also pneumococcus pneumonia. That's called pneumococcal pneumonia. Streptococcus pneumonia or pneumococcal meningitis, and then Haemophilus influenza is the third type of bacteria that can cause meningitis. Viral meningitis is less severe. Usually mumps, measles, rarely HIV will cause meningitis. One of the big concerns people have about the measles is the small chance that a patient can get meningitis from that. And then chronic meningitis can happen as well, and that's from a slowly developing infection. Vague recurrent headaches, low fevers, usually patients are very fatigued, exhausted. That might occur in immunodeficiency states like HIV infection with AIDS, also tuberculosis, chronic fungal infections, and the treatment here is with the appropriate antibiotic therapy. So the physical exam findings are pretty characteristic here, and we're going to see meningeal irritation signs. And then labs, our complete blood count, blood cultures might confirm. The lumbar puncture is only done after a CT scan is done, because if there is increased intracranial pressure, doing a lumbar puncture, you would actually have cerebral spinal fluid just squirting out of the lumbar puncture, and that would decrease the CSF pressure too rapidly. So a CT scan has to be done first to check for any evidence of increased intracranial pressure. One of the things that can be seen is the ventricles look compressed or even enlarged with that increased intracranial pressure, and there's some maybe deviation of the ventricles as well. So this is a medical emergency. You need to refer to the emergency department. Without urgent treatment, the acute bacterial meningitis can lead to death via septic shock or coma by spreading more to the brain. Viral meningitis will typically subside within a few days. There's no specific treatments except for just kind of supportive treatment, but that might result in persistent long-term headaches. Generally for the bacterial meningitis, we use antimicrobials, so benzyl penicillin by injection or IV antibiotics. Corticosteroids might reduce inflammation to the brain. So unfortunately, even with rapid treatment, 15% of patients with acute bacterial meningitis will die. Many will also have permanent neurological damage, deafness, recurrent headaches. So really the emphasis in the medical community here is on prevention, and that's through immunization. There is meningitis B and C vaccines for the meningococcus, and then there's a pneumococcus vaccine. And also there's a Haemophilus influenza B immunization. And then there's potentially antibiotic prophylaxis for people that maybe are around others. This is not uncommon in like dormitories and whatnot for this to spread. So that is meningitis. Encephalitis would be inflammation of the brain. This is a deeper condition than meningitis, usually caused by viruses. And this can actually lead to degeneration of the brain over time. So a classic example of more of a chronic encephalitis would be things like prion diseases. So that would be, for example, Creutzfeldt-Jakob disease. That's that's obtained essentially by eating neural tissue, and the prions are really weird. They're actually just misfolded proteins, and they cause other proteins in your brain to misfold when they get into the body. Late-stage syphilis and HIV also can cause chronic brain degeneration. So encephalitis is specifically reserved for just describing inflammation of the brain, not these more chronic infective conditions. Most common viral causes would be mumps, measles, and herpes simplex, and rabies, and then potentially HIV with opportunistic infections. Usually milder symptoms than meningitis. There's headache and fever, drowsiness, confusion, mood changes. There can be seizures and persistent brain damage as well. So here imaging can be helpful, and EEG as well for checking for seizure activity. Again, medical emergency, antimicrobials can be used. Again, this is usually from viruses, so antibiotics would not work. But antiviral agents like acyclovir for herpes viruses might be indicated. And then again, prevention is kind of the mainstay here with the MMR vaccine. So here's just, again, some red flags to consider. These would all be level 4, need for level 4 intervention. But progressive headaches with vomiting with a time scale of weeks to months. This could be a slow rise in intracranial pressure, and so that's something that might suggest a brain tumor. Brain abscess is another type of infection, usually bacteria. You form a pocket of infection in the brain, and then potentially extradural hemorrhages. All that would be a red flag. Sudden, very severe onset headaches, again, the thunderclap headache, and that would be potentially suggestive of a subarachnoid hemorrhage. And then severe headache with neck stiffness, think meningitis, potentially encephalitis. If there is signs of, arching the neck, pruritic rash, and so forth, that's pretty ominous. That's going to tell us more with the rash that it's potentially meningococcus. And then severe headache with stiff neck that develops over a few hours to a day with fever and bruising, non-blanching rash, drowsiness, confusion, that's meningococcus. And then a severe one-sided headache over the temporal, think temporal arteritis, especially if it's the first time this headache has occurred in the patient, especially in a male patient over 50. And then long-standing history of worsening progressive headaches with kind of those generalized symptoms we've already discussed about loss of function that might suggest a brain tumor. So keep those in mind. Again, these would all be potential need for urgent referral. So that covers it for headaches and the most classic types of benign but also non-benign headaches you need to be aware of clinically.